Chapter 19, Hospital Outpatient and Inpatient Billing. The learning objectives for Lesson 19 is 1. Explain the revenue cycle of hospital claims. 2. Manage the discharge not final billed report. 3. Discuss the 72-hour rule. 4. Explain utilization management and its role in the hospital reimbursement system. 5. Explain the charge master. 6. Explain the International Classification of Diseases 10th Revision Procedure Coding System, the IC10 PCS. 7. Explain the role of the IC10 PCS in hospital billing. 8. Explain the role of current procedural terminology in hospital billing. 9. Explain the role of Healthcare Common Procedural Coding System. 10. Assign the present on admission indicator. And 11. Explain the reimbursement methods used when receiving reimbursement for Medicare hospital services. Admissions procedure. To maintain a quality of standard of care, it's important to first identify the standards of patient care and develop a strategy to meet those standards. The Joint Commission, TJC, American Hospital Association, the AHA, and Centers for Medicare and Medicaid Services, CMS, provide guidance to hospitals to meet quality patient delivery goals. These organizations have established specific procedure guidelines that hospitals must follow to ensure quality patient care for pre-admission tests, such as laboratory tests, X-rays, and electrocardiograms, also known as EKGs or ECGs. Admitting procedure for major insurance programs. Some services require prior approval from the insurer before they can be performed. This is known as pre-authorization. Private insurance, either group or individual, and you need to know the commercial insurance and managed care. On emergency inpatient admissions, the managed care program should be notified the next working day or within 48 hours, and then an authorization number must be obtained. That's usually called a retro auth. In non-emergency to hospitals with a managed care contract, what must the physician do to obtain authorization for the length of this hospital stay? Is you want to refer to the primary care physician. Admitting requirements will differ amongst insurance companies. Between Medicare and Medicaid, the treatment authorization form is required for Medicaid patients. Pre-approval is not required for Medicare patients, but their admittance should be certified by AEPS. TRICARE, what is need to be obtained to a civilian hospital, is a pre-certification. And workers' comp, since employees do not carry workers' compensation insurance cards, what must happen before a hospital or a physician's insurance claim can be submitted? An injury report must be complete and submitted to the Workers' Compensation Insurance Company and the State Industrial Accident Board before the hospital or physician's claim can be submitted. Pre-admission testing. Routine blood and urine work. When a laboratory panel of tests is performed, each separate test must be itemized and must show the clinical benefit for each test performed based on the patient's diagnosis. Diagnostic studies, laboratory tests, chest x-rays, electrocardiography, also known as your EKG or ECG, and this is all part of what the pre-admission testing is. The 72-hour rule. If patient receives diagnostic tests and hospital outpatient services within 72 hours of admission to a hospital, all such tests and services are combined with inpatient services. Pre-admission services become part of the diagnostic related group, the DRG, payment to the hospital, and may not be billed separately. And if this rule is not followed, fraud and abuse may be considered. Exceptions to the 72-hour rule. Services provided by home health agencies, hospice, nursing facilities, and ambulance services. Physician's professional portion of a diagnostic service. And pre-admission testing at an independent laboratory when the laboratory has no formal agreement with the healthcare facility. Utilization review. The UR process determines whether admissions are justified. The process also anticipates length of stay and concludes the expected discharge date. The department conducts an admission and concurrent review and prepares a discharge plan on all cases. Utilization review, UR, companies exist for self-insured employers, third-party administrators, and insurance companies. Quality Improvement Organization Program. These are composed of licensed doctors of medicine or osteopathy actively engaged in the practice of medicine or surgery. While working under federal guidelines, these physicians evaluate other physicians on the quality of professional care as well as other factors. They take into consideration admission review, readmission review, procedure reviews, day outlier review, cost outlier review, DRGs validation, and transfer review. Coding hospital diagnoses and procedures. The diagnosis codes come from the IC9-CM or IC10-CM. The procedure codes come from the current procedural terminology, CPTs, or the Healthcare Common Procedure Coding System, HCPCS, IC9-CM Volume 3, or ICD-10-PCS. The principal diagnosis is the first listed diagnosis. It's the reason patient is seeking medical care. And on outpatient claims, it's known as a reason for the encounter. The principal diagnosis is subject to 100% review. These are arteriosclerosis, heart disease, ASHD, diabetes mellitus without complications, right or left bundle branch block, or coronary atherosclerosis. Coding inpatient procedures. The coding structure in IC10-PCS is significantly different than the IC9-CM Volume 3. IC10-PCS code drafts can be downloaded for free from the CMS website. Character definitions. Because of the detailed nature of the IC10-PCS coding set, the successful coder must understand the procedures and the type of operation performed, the exact body part, and the surgical approach. Use the alphabetical index and tabular index when coding from the IC10-PCS. The definition characters are: character 1 is the medical section. Character 2 is the body system, such as your respiratory, integumentary, cardiovascular. Character 3 is the root operation. Character 4 is the body part. Character 5 is the approach. Character 6 is the device. And character 7 is the qualifier. Tabular index and the alphabetical index. The tabular index is organized first by section and then by body part. It prevents coders from choosing erroneous codes. The alphabetical index is not advisable to rely on this index for accurate coding. You never ever code straight from the index. Coding hospital outpatient procedures. The CPT codes are updated each year. Billing software must be updated with new codes to receive maximum reimbursement. Your HCPCS Level 1 CPT coding system, that means that you must use your up-to-date CPTs. Use HCPCS to obtain medical procedural codes for Medicare and some non-Medicare patients on an outpatient hospital insurance claims that are not in the CPT code BRC. Use modifiers as noted in CPT and HCPCS guidelines. Modifiers. Modifiers are two-digit alphanumeric codes that modify or provide more detailed information on the procedure. Refer to Appendix A of the CPT manual for a full list of all the modifiers. Charge Description Master. The Charge Master database must be kept current and accurate to obtain proper reimbursement and must be regularly audited. The Master Charge List is the Charge Description List, is a computer file unique to each hospital that accommodates the charges for items and services that may be provided to patients. Revenue codes usually lines up with specific lines on the CMS 1450 or the UB04, the form used for inpatient claims. The services and procedures are checked off and coded internally. And data included is the procedure codes, the charge, and the revenue code. Electronic claim submission. Paper claim submission is prohibited except under the following conditions: small provider claims, roster billing of inoculations covered by Medicare, claims for payment under a Medicare demonstrated topic that specifies claims to be submitted on paper, Medicare secondary payer claims, claims submitted by Medicare beneficiaries, dental claims, claims for services and supplies furnished outside the U.S., disruption of electricity or communication connections, claims from providers that submit fewer than 10 claims on an average during a calendar year. Reimbursement Methods. Ambulatory payment classification is a method based on procedure rather than diagnoses. Services are associated with a specific procedure or visit and bundled together. Bed leasing, capitation or percentage of revenue. Capitation is reimbursement to the hospital on a per member per month basis. Then reimbursement methods could be case rate, the contracted rate, DRGs, differential by day in hospital, differential by service type, fee for service, fee schedule, flat rate, per diem, percentage of accrued charges, the periodic interim payments, the PIPs and cash advances, relative value studies or scale, the RVS, and resource-based relative value scale. Usual, customary, and reasonable, the UCR, withhold, managed care stop-loss outliers, charges, discounts in the form of sliding scale, and sliding scales for discounts and per diems. And what is a sliding scale? And it is a form of discount with a limit in which the percentage amount increases based on hospital numbers. Example could be the number of bed days per year. Hard copy billing is used for insurance companies that are not capable of receiving electronic claims. Receiving payment is after receipt of payment, patient sent net bill listing, any owed deductibles, coinsurance amounts, and charges not covered. Predetermining payment. Now, the difference between cost-based systems and the prospective payment system, the PPS, is that cost-based systems weren't efficient because the amount charged varied physician to physician, even though the same service was rendered, and the amount charged often didn't take into account the variables such as where the physician practiced, malpractice insurance rates, and the amount of work. It was designed to increase reimbursement for sicker patients. Medicaid, TRICARE, and other private insurance companies develop their own PPS. Medicare Severity Diagnosis related groups, the MS-DRGs. The DRG-based two-tiered system is used for reimbursement to hold down rising healthcare costs. The DRGs is a prospective payment structure on which hospital fee reimbursements are based. The MS-DRG group diseases, possible related diseases, and medical treatment into a single code. Clinical outliners. They're a unique combination of diagnoses and surgeries causing high costs for very rare conditions. The long length of stay or day outliners no longer apply. Low volume DRGs. And then inliners are hospital case that falls below the mean average or expected length of stay. Death, leaving against medical advice, or admitted and discharged on the same day. Hospital Outpatient Prospective Payment System, the OPS. The procedure code is primary axis of classification, not the diagnostics code. Reimbursement methodologies based on the median cost of services and the facility cost to determine charge ratios and copayment amounts. Adjustment for area wage differences are based on the hospital wage index currently used for inpatient services. OPS may be updated annually. The Ambulatory Payment Classification System. The procedures that APS are applied to are the ambulatory surgical procedures, chemotherapy, clinical visits, diagnostic services and diagnostic tests, emergency department visits, implants, outpatient services furnished to nursing facility patients, not packaged into a nursing facility consolidated billing. Partial hospitalization services for community mental health centers. Preventative services, example of colorectal cancer screenings. Radiology, including radiation therapy. Services for patients who have exhausted Medicare Part A benefits. Service to hospice patients for treatment of a non-terminal illness. And surgical pathology. And this concludes the lecture of Chapter 19, Hospital Outpatient and Inpatient Billing.